and talk to us about EMTALA and what that means for our facility. So Heather, if you want to come up.
He said make sure to talk in the mic. Okay. Is East online too? They should be. He said they should be. Okay. And North. And North.
Right, I know, yeah. So initially this was not supposed to be in Probasco, but it got moved, I guess, probably because of the PowerPoint presentation and needing to record the session for other use. So I hope I don't bore you too much today, but as you guys probably are aware, this is a very big topic, and we want to make sure that you understand EMTALA to the extent that you're dealing with patients in the ED, you're running into EMTALA every single day, federal law. And I know you guys have been educated on it. I know there are probably different aspects of the big law that is EMTALA that you've talked about more than others. So if we get to a point where you've got questions or real scenarios, I would frankly rather you raise your hand and go, hey, let's talk about a scenario. What do you think about this? Because I do know that you guys have touched on EMTALA quite a few times, so I don't want to just keep saying the same things without touching on what you are dealing with most frequently in day-to-day care. So essentially, the Emergency Medical Treatment and Active Labor Act covers, if you think about it very basic, just strip it all back, what does it cover? It requires primarily three things, okay? One, that we screen our patients, and you guys have heard that, the medical screening exam, right? MSE. Have you guys heard the acronym MSE? We love acronyms in healthcare. So, and the whole point of the MSE, we'll come back to this, because this sounds easy, and it can get complicated in real-life situations, what an actual medical screening exam is. But essentially what you're doing is determining whether there is an emergency medical condition, because as you guys know, a lot of people come to the emergency room that do not have an emergency medical condition, right? And if they do, oh, my kid's got a sore throat, and I'm not taking them to the primary care provider, I've shown up in the ED. Is a sore throat an emergency medical condition? I mean, I guess there are situations where it could be. But if it's not, does EMTALA apply? Up until the point that you rule out an emergency medical condition, it applies. But once you've seen that patient, done that medical screening exam, and go, it's a sore throat, you're stable, it's not an emergency, EMTALA no longer applies, okay? We'll come back to that. Number two, it requires you to stabilize patients that do have an emergency medical condition. That's number two. That's a biggie. So you do your medical screening exam. Question number two, have we stabilized the patient yet? If we've not stabilized that patient, EMTALA is still operating. It still applies. So that's a key piece of this big federal law. And then third, you can transfer patients, but you've got to follow very strict guidelines, and it restricts when you can transfer the patients. You guys know the background of EMTALA, why it ever even came into existence. Why do we even have this law? Because it used to be that if you didn't have payment, emergency rooms across the United States would turn patients away, and people were dying. And so the federal government stepped in, and it was known as the anti-dumping law. We are not going to let you watch people die because you're waiting to get their insurance information. Or you're telling them, oh, you can't pay for our services, go somewhere else. That's what was happening. And so they said no more. So these are the big three things. If you think about it very simplistically, that's what the law covers. That being said, it is a huge, big federal law with a lot of specific issues. If there's a question you ask today that I don't know the answer to, I'm going to own that I don't know the answer to it rather than tell you something that's incorrect. I'll go back and research and find an answer for you, okay? So we can be in communication. If you have a question, you can email me, you can call me. I work at Erlanger. I'm in the Whitehall building. And by the way, in my prior life before I came here, I was an outside practicing lawyer representing nurses, doctors, and area hospitals. That's my background before I came to Erlanger. I've been here now about 5.5 years. But I'm open to any of your questions. Okay, so what does it mean to come to the ED? So that sounds easy enough too, right? When has a patient come to the ED? So EMTALA has developed over the years. Does it mean that you've walked through the doors of the emergency department? Yes. Does it mean more than that? Absolutely. What if there's a patient that fell out in the parking garage? Does that count? Have they come to the ED? Look at number 2, bullet point. If they've come within 250 yards, so think about 2.5 football fields. That's the easiest way for me to think of that. Perimeter around the main building. And they show that they've got an emergency medical condition or asking for emergency care, or a reasonable person would look at them and go, oh my gosh, they need emergency help. If they're within 250 yards, 2.5 football fields, we provide care. They've come to the emergency department. Now, there are some caveats to that, too, but think of it generally in those terms. They don't have to have walked through the front doors and come up to our registration desk, okay? And so obviously, if they've walked in, if they've come to the main campus of our hospital, including parking lots, sidewalks, driveways, so if they're on the sidewalk outside the ED, let me tell you why this came to being so you'll understand. This didn't used to be the case. So when EMTALA first came out, it was simple, right? And then as every law in the history of human laws have, over time they get more complicated because real life comes into play and then you have to play with the law. So there was a case in Chicago, this was a very devastating case, where a kid, I think he was maybe 14 years old, was shot. And and I don't know if it was gang violence, I believe, was what was behind it. But in essence, he was dragged to outside the doors of the ED and left. And the hospital wouldn't go out and get him. Because they said, well, we're not allowed to leave the building. And he died. He bled out. And so because of that, the federal government stepped in again through EMTALA and said, no, they don't have to walk through the doors. You guys knew you were on notice there was a kid bleeding out on the sidewalk. You've got to go get them and bring them in. So that's how we came up with what's called now the 250-yard rule, okay? And that we're dealing with this issue right now. What about an ambulance that's coming inbound ambulance? It used to be that it was just if the ambulances are hospital-owned, which, by the way, we don't have hospital-owned ambulances at Erlanger, so it's not an issue for us. If they're hospital-owned and that ambulance went and picked up somebody out in the field, once they're in that ambulance that's hospital-owned, they've come to the ED. Now, we don't have that. Oh, yeah, go ahead.
So if someone falls in the parking garage, we don't call an ambulance, we go out and get them?
That we have some rules around that. Number one, we have to know about it. I don't want to get too caught up in the 250-yard rule right now because that's a response plan that the health system is responsible for putting in place, okay? That can get very complicated. How far do we have to go? Do we run across public streets? No. Why? Because we don't want our providers running into traffic to go get people and bring them in, right? Even if they're within 250 yards. So that can get a little complicated. But typically what we want to do is this. Usually we have a plan in place for that, but it would be that if we know about it, number one, because we don't automatically know, right? We have a response team that would go and assess that situation and see do they need to go and have emergency care or not. Okay? So we do have a protocol in place for that. That's more of a system issue. I'm sorry?
How do you get a hold of the response?
Usually the house supervisor, I know we don't call them that anymore, patient flow. Yeah, patient flow manager. I can't help it. I still call them house supervisor. But yeah, patient flow manager is usually the one that goes and assesses and then determines, do we need a wheelchair, do we need an ambulance? It could be a situation where the person's bad enough, depending on where they are within that 250 yards, we might need an ambulance. But yeah, and then they would bring them into the ED. Not that the whole ED would have to go out to them, but we would have to have a response plan, right? So, and I don't want to get too caught up today in the inbound ambulances, because again, that's something that our health system has to take care of. We have to work on that. But just to let you know, those are issues. So it's not just an easy analysis of they've walked through the door, right? It can be more than that. And what we just talked about is true. If they come in, if a patient walks in the door and asks to be seen, then we have to see them, right? Can't say, well, do you have an insurance card? Can you pay for this service? We have to see them. But the same is true if we see somebody. The easy example would be somebody falls out, cardiac arrest, and you see them laying there. They're not asking for help, but we know as a reasonable person they need help. That's also that also counts for someone coming to the ED and requesting medical attention. So the medical screening exam, I want to talk about this quite a bit today. A medical screening exam is given to those seeking treatment for a medical condition, regardless of their ability to pay. And again, the purpose is to determine whether an actual emergency medical condition exists. That's what you're looking for. What is an emergency medical condition? This seems easy enough, but it's not always. It's actually defined in federal law. So we have acute symptoms that are so severe that if we don't give immediate medical attention, this person's health could be in serious jeopardy, serious impairment to bodily functions is possible, or serious dysfunction of any bodily organ or part. That is how federal law defines an emergency. A qualified medical provider has to make that determination, right? So I think, Whitney, under our bylaws, it's doctors, who else? Okay, an APP level has to make that determination. Okay, not nursing staff, not nursing staff. It's defined by law. It has to be a qualified medical provider to make that determination. And then, of course, with a pregnant woman, do you guys have pregnant women come in? Yes, 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 okay. If for a pregnant woman who is having contractions, this is a medical emergency, that there is inadequate time to effect a safe transfer to another hospital. Of course, here we deliver babies, so that's not an issue. Or that the transfer may pose a threat to the health or safety of the woman or the unborn child. Essentially, we would get them right upstairs for the most part. Whitney?
So as far as my understanding is if a woman is having contractions, we have to check them before we can roll with them. So if the baby is presenting, we have to deliver.
Yes, that's right. If they're that's right. If she's in the process, then you would have to continue that process and not try to stop it. But you're right. You would absolutely not just send them up. You would check the patient to see what's happening. And we can't differentiate with patients. Let me give you an example. If you've got the Cadillac of insurance, and then the next patient that comes in does not, if those two patients present with the same symptoms, you've got to treat them the same. It doesn't matter whether they can pay. And that's what happens, you guys, when we have the state come in to check and see, did Erlanger have an EMTALA violation in this particular situation? What they're looking for is whether we provided care to this patient that they would expect to see us provide to any other patient with insurance. So it has to be a comparable exam. You can't treat people differently based on ability to pay. If the medical screening exam shows that there is no emergency medical condition, we've already said this, the EMTALA obligation ends. But who decides when there's no medical or emergency medical condition? Who decides that? The QMP. That's right. Of course, if the medical screening exam reveals that there is an emergency medical condition, here's where it gets interesting. And Whitney and I were just talking about this before we started this morning. When does the medical screening exam end? It doesn't end. It is an ongoing process that continues until that patient is stabilized or transferred if they need to be transferred. Okay? It doesn't end. So when you think of triage, triage is a distinct thing that happens, right? Patient goes, they meet with the provider does a triage assessment, and then they've been triaged. Done. Triage is done. Medical screening exam does not work that way. It starts with triage, but it continues because why? Why would it continue? Why would it do this ongoing process? Because you're going to keep screening that patient. If they have an emergency medical condition, you're going to keep screening that patient. So it's not going to end, and it doesn't end until the patient is either stabilized or transferred if they need to be transferred. It is not an isolated event. There's a lot of confusion around this. A lot of times we think of an MSC as being, okay, we've done the MSC, check, it's done, we've screened them. and there's an emergency medical condition, screening done. Again, it is not. It is not until that patient is stabilized.
Can we give an example? Can we use the April example for them so that they know what that means?
Yes. So let's say patient comes in to the ED, and they're triaged. They're placed back out in the waiting room. An NP comes and sees the patient, starts a workup, actually places orders. Some of those orders start to be carried out. Is the MSE done? Patient's not stable yet. MSE is not done. So then, let's say the NP leaves, there's a handoff, and there's even a note in the chart that says patient needs to be admitted. Because, see, we know that once a patient is actually admitted, that's the third factor that would cut off EMTALA. If the patient is admitted, EMTALA does not apply anymore. But they actually have to be admitted, not needs to be admitted, okay? But let's say there's a note in the chart that says patient needs to be admitted. And that note's placed in the chart by, let's say, the qualified medical provider. They're still in the ED. Maybe they're still in the waiting room. Is the MSE complete? It's not. It's not. So again, that MSE is not complete until the patient is either stabilized, transferred, or they're admitted. Okay? What are we usually talking about with an MSE? We're looking for documentation of vital signs on the patient, obtaining their history, a documented physical exam of the involved area or system, if needed, any ancillary tests, specialists. We can consult specialists. That's all part of the MSE still. Lab tests, procedures, CT scans, imaging services, and continued monitoring. We have to have documentation of our continued monitoring. We actually have to monitor, and then we need to document that we're monitoring that patient. If that's absent, then we've got a problem under federal law. And if they're in the waiting room and we're providing care, it's the same thing. Okay? It's the same thing. It doesn't matter where we have physically put that patient. So if the medical screening exam reveals the emergency medical condition, now we've got to provide our stabilizing treatment within our capabilities. For a pregnant woman, to Whitney's point, that means deliver the child and the placenta. All of it has to be done to stabilize a pregnant patient that comes in labor. B, transfer the patient to a medical facility. So let's say that we don't have the capability for whatever reason. It could be that we don't have space, right? If we don't have anywhere to put a patient that needs to be admitted, we might need to transfer that patient. And if we need to transfer the patient to another medical facility that does have space, we've got to provide stabilizing treatment within our capabilities before we do that. We can't send unstable patients on. Now, I talked to Whitney. I know you guys have had education around transfers. I'm touching on it here too, but I really wanted to focus a lot on the medical screening exam. All right, so if we are transferring a patient, have you guys worked on a transfer of a patient before? Yeah. For instance, the easiest, lowest hanging fruit example is we don't have burn specialty. So if we have a patient that comes in with burns, that needs burn treatment, we have to stabilize them within our capacity, and then we've got to transfer them to a burn facility, right? Somewhere that can take care of that. We have to provide medical treatment within our capability to minimize the risk of that transfer. We've got to get their written consent for transfer. And you guys have seen the form. It's now, of course, in EPIC, the certificate of transfer with the boxes that you check. You guys seen that? Okay. assure that the transfer takes place with qualified personnel and equipment. This is where we get down to how do we get the patient transferred. That is going to be a physician decision. And in fact, I believe on your EMTALA transfer form, that's under the physician certification section. So that's not something you have to deal with. But the physician does. They've got to make sure they're appropriately transferring that patient. If that requires an ambulance, then we got to send them by ambulance. And we've got to send copies of their medical records related to that medical condition. We have to do that for continuity of care purposes. Now with EPIC, that's a lot easier.
The patient can't sign. Do you have to wait for a family member to sign for them? Agree to send?
So yes, usually you want to have an authorized representative sign to send the patient on. Now, if there's no one available to sign for the patient, is that what you're asking for?
Like, say, okay, we're talking about burn patients. Like, if you know you need to get your burn patient out, but you're still trying to wait for, like, say, a family member to sign for them to be able to agree to go.
I would say then you want to try to get them by phone. If
And then you could do it that way.
yes. I mean, you don't want to delay care to the point that it's going to adversely impact the patient. But yes, if you can get consent, you do want to get consent. And if that means by telephone, then by telephone. But if it's going to hurt the patient, then other things can be, the doctor can sign for it. Okay? So what does stabilized mean? What does it actually mean? It means there's going to be no material deterioration. This is federal law again. I know, don't go to sleep yet. No material deterioration of the condition is likely within a reasonable medical probability to result from the transfer. We don't want the patient to decompensate. And again, for a pregnant woman, delivery of the child and placenta means they're stabilized. The patient is stabilized if the emergency medical condition has resolved, even though the underlying medical condition may persist. It doesn't mean they're all better necessarily, right? It just means that the emergency condition is resolved. Now, I know we don't deal with behavioral health patients here, but for psychiatric conditions, the person is protected and prevented from harming themselves or others. That's when they're considered to be stabilized. We're only going to transfer non-stable patients if, and again, this is going to require a physician to come in and provide certification around this. The patient or someone acting on their behalf requests a transfer in writing after being informed of the risks involved and that we have an obligation to treat. But they can request to go somewhere else, okay, even if they're non-stable. But we've got to tell them the risks, and we've got to tell them that we have an obligation to treat them. And then two, a physician certifies, or two, a physician certifies that the medical benefits from the transfer outweigh the risks. For instance, in your burn scenario, they may need to get transferred even if they're not stable, because they'll benefit more from being in a burn facility that specializes in that care. We are typically not the transferring facility, right? Erlanger is typically the receiving facility. So this is what we deal with most often, and this is where I get a lot of phone calls about, was this transfer appropriate? What are we obligated to do as the receiving facility? We have to have available space and qualified personnel to treat the patient. So you guys are aware now that we've worked on a revised NEDOC scoring system. Are you aware of that? For staging? Okay. Some yes, some no. But essentially what we're trying to do now is we've lowered that threshold to go ahead and communicate out that, hey, we may not have capacity right now to take your patient outlying counties, outlying facilities in Alabama or wherever that are sending patients over to us. We may not have that. So we've revised that scoring system so that staging gets triggered, it's called advisory, but it's a staging system, and we go on advisory at a lower level, at a lower threshold than we used to. We're trying to offload some of the impact to the ED. But if we have available space and qualified personnel, we have a physician that accepts transfer. Those calls typically go through EROC. I wish all of them did. They don't always, but I wish they all went through EROC. And because we are a regional referral center, we are, and we have specialized capabilities that others don't, there are some patients we absolutely cannot refuse to accept if we have capacity.
So what's the definition of a qualified personnel?
So, for instance, if we didn't have any cardiac physicians, we'll just take a, or let's say we didn't have neurosurgery. It's hard for us because we have almost all specialties. Listen, we don't have the burn specialty though, right? So why would we agree to take a burn patient from a rural facility? We wouldn't, because we don't have the capability, we don't have qualified personnel to care for that patient. So that's an easy example. Most specialties we do have. That's why we are typically a receiving hospital and not a transferring.
Is nursing staff in that qualified personnel?
I think at that point it would be, are you saying by numbers? Give me an example, Whitney.
So
What do you mean by that?
Say the ED is running with 7 nurses, and they've already got 20 holds and 40 ER patients. So they're already past their...
So that would trigger the new staging system that's been put in place. Your example would trigger the new staging system that's been put in place, right, Jan? You've seen that? And that should, like for instance, I think there are 3 ways. I don't want to get too much into that because I don't know that very well. Donna Borden could speak to it in super duper detail. But what you just described would put us on staging, or advisory. We would go into advisory.
At 40 holds, we would be on advisory.
Yes, at 40 holds. That's right. Or under the new system that they've put together, that the throughput committee has put together, an emergency room physician can say, it's unsafe. Doesn't have to meet the NEDOC score requirement, does not have to meet the holds requirement.
Heather, I will say, there is that you need doctors when we don't, but if we have qualified personnel, it may be a reshuffling of what we have. It'd be just like if someone were requiring surgery, doesn't need it because they're in surgery with a patient. We have to readjust what we do. So it could be that we readjust within the staffing model of what we have. But that staging would take care of if the physician feels like we can't accept them.
Yeah, exactly.
We feel like we're not staffed well enough, doesn't mean that we shouldn't accept the patient we offer the service. You've got to reshuffle and think about what you're doing.
Yeah, and to get back to your base question that you asked, what you're really looking for is not, do we have nursing staffing ratios? Under EMTALA, what they're looking for is, do you provide that burn care that this patient needs? You don't, then we don't come to you. Then you don't need to accept that patient. So have you guys encountered the situation where the patients are the ones who refuse to be examined once they come in? I know you have, because I get called about it sometimes. So patients who refuse exam or treatment at all, which you question, well, why'd you come here in the first place, or transfer. I don't want you to transfer me. I want to stay here, even though you can't, you're telling me you can't provide the care I need. I want to stay. What do we do in that situation? We still have to make the offer to examine the patient, treat them, or transfer them. Still make the offer, even if they're saying no way. And, of course, we document that. Always document. Document the exam, treatment, or transfer was refused. We're going to document that the risks and benefits were explained to the patient. If you leave right now, here's what could happen to you. Here are the risks. You could die. You could bleed out. You could have a stroke. You could, those medical risks based on their condition. It's going to vary based on what condition is presented to you. And then document the basis for the refusal of treatment or transfer. Why are they refusing this? Take reasonable steps They won't all sign a form saying that they're leaving, right? That would be the perfect world, and we don't live in that perfect world. But we would love them to sign a form saying they're refusing. But when they don't, okay, we can't force them to put pen on paper, but we can document that they refuse to sign, which is all you do. They refuse to sign the form saying that they're refusing treatment. They're refusing everything. The big issue, can we delay exam to ask about payment? No, 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 no. When that patient comes in, if they need care, we start initiating care, right? We'll deal with payment later, but let's go ahead and initiate care. Start taking care of that patient. Do not suggest to the patient, y'all, this is where we run into more problems that I get called about, right here. Please take note. Do not suggest to the patient, wait, here's the long wait. You can go to North and be seen quicker. If they've come through those doors, they come up to you and say, what's the wait time? I don't know. Patients are seen based on the care that they need and how urgent they are or emergent their medical condition is, so let us get you taken care of. Don't say, oh, it's going to be a long wait tonight. Avoid any discussion of those wait times if they're going to be really long, because the way that the government looks at that is you're discouraging patients from being in this facility, AKA that you're turning them away. That's how they look at it. You may look at it as being honest. That is not how the federal government looks at it. Don't suggest they should leave and go elsewhere, and don't tell them, I don't know if insurance is going to cover this for you. None of that. We just need to see you. We just need to get you taken care of. Let us take care of you. We're happy to help you. Here's another one we see quite a bit. Children's versus adult. The common scenario that I get called about is we have a child by law. What age is that? Yeah. It's actually 17 or younger technically. I know we see people in children's older than that, but technically by law it's up to 18, okay? If they come in to adult ED asking for emergency care, do we point and say, you're in the wrong place, you need to go to children's, it's over there? That we don't want to do that, okay? If they show up in the adult ED, if a child shows up in the adult ED, or vice versa, seeking treatment, and they can safely be taken to the appropriate ED, they need to be accompanied. We need to offer a wheelchair assistance. We need to go with them. Because what happens if they're going to, we point and go, hey, go over there, and they walk outside the building, they don't know where they're going, and then they fall out. We've got problems. Because they've shown up at our ED. We didn't do a medical screening exam, did we? We didn't do anything. So if we're going to try to help them, number one, we're going to have to screen that and see, are they okay to even go that short distance? Because they've shown up to an ED. It doesn't matter that it's adult and not children's. We need to be very careful around this. We've had several issues around this recently that have been lifted up. We need to accompany the patient to the appropriate area. Fine. I think it's going to, that would be optimal. Or call and get assistance and get him there safely. That issue has not come up so much. What I have seen, though, is where people you have someone show up at the wrong ED, and rather than making sure the patient is okay and getting them where they need to go by traveling with that patient, right, so that there's somebody medical with that patient going with them, we have somebody point and go, you're in the wrong place. Go out here and then go down there and then turn left and then who knows? And what if they leave? We've just turned them away from an ED. for EMTALA purposes. So to your point, what I would say is you're going to have to assess, every clinical situation is different, every single one, and I am not clinical. And you don't want me opining about what medically needs to happen right then. Yeah, optimally we would do a medical screening exam before we take the patient to the new place. But if they're walking, talking, everything looks good, and we have somebody transport that patient, I'm comfortable with that. Again, there's got to be some critical thinking going on. You know, in a situation, you know, you're clinical. You know whether you can get that patient safely over there most likely, right? Versus, oh my gosh, we need care here and now, call it rapid. We have resources to take care of that patient if they show up in children's, and they should, they should be, quote unquote, in adult. We've got resources to take care of them. If they're falling out, what would you do? Clinically, what would you do right then? Is that the quickest way to do it, for them to get the best care?
Yes, the safest care because they're used to taking care of that heart attack or.
Right. Would you point and say, go out the doors over here? No.
Okay, from a legal standpoint, this MSC that we're discussing, say a 60-year-old does walk into children's, does that mean they need to be arrived in Epic and have a doctor document on them beforehand, or is it just having a qualified medical professional look at them and going, yeah, dog, you're in the wrong spot?
What do I prefer?
Because I can tell you what happens if we arrive them into Epic and we get a doctor document on them with a medical screening, and then, you need the vitals, you need this, you need that. You're significantly delaying their care.
Right. Yeah, that's what I have been told. So, and I didn't realize.
Epic?
No,
Okay.
let me back up.
Okay.
What do I prefer? Forget Epic for a minute. I prefer that there's documentation of what happened. So if we're getting them over, we are getting them to where they need to go. It could be documented later, right? I'm asking you. I don't know. I'm not clinical. I don't document in the chart. Could it be documented for the children's ED?
If you create the chart, yes, it can be back-timed and documented, but
I don't want to delay care for documentation.
Yeah.
Let me say that. I would never support legal requirements over a patient's life.
okay.
So you don't want to delay care to a patient for some documentation standard. You can always, so what I used to do was malpractice work, okay? You can document, from my standpoint, from a malpractice standpoint, you could go and document patient showed up at Children's ED, was transported via wheelchair by RN so-and-so to adult ED, providing care. That's fine. What I don't want you to do is and a lot of this is critical thinking, right? Because the law cannot encapsulate every situation you face in real life. It just can't do that. That's why we struggle with these kinds of questions that you just asked. Because, yes, the perfect example would be they arrive in an ED and you register them right there, but that's not always real life. Now, do I want a log of everybody that shows up at the ED, even if they end up leaving? And yes, absolutely. But what you're saying is they would show up in one ED, need to go to the other one to actually get the care they need. If you document an MSC here, you're actually delaying their care and harming the patient. I never would say delay care, harm the patient, but make sure you get that documentation. We can take care of documentation back on the back end. Now, I don't know if we want to go too much into this. Can a receiving hospital refuse an appropriate transfer? Meaning, can we just say, gee, we don't want to take that patient? If a transfer is appropriate, then the only valid reason for us to refuse the transfer is if we lack the specialized capabilities to treat the patient. That's it. Now, if we don't, is it a different question? Do we have space? Well, that's part of the capabilities. If we don't have space to take care of a patient, then that changes this analysis, because then maybe we can't actually take care of that patient. We have patients come to us from facilities, I use Alabama as an example, but it can be pick your state that touches us, and they pass 2 other trauma centers on the way to Erlanger. Why? Because those trauma centers may have been on divert or advisory, and we aren't. So the point being, if you don't have space, that is a consideration. We keep talking about this, but I do want you to know I get this question a lot of when does our EMTALA obligation end? Patient comes here, when does it end? When the physician or qualified medical person has decided that there is no emergency medical condition. Or if they do have an emergency medical condition, let's use our burn patient example, that's the easiest one. But we've appropriately transferred the patient to a burn facility, okay? Or 3, there is an emergency medical condition, now the patient's admitted. Once they are moved over into the admitted world, EMTALA stops. And I'm not going to go too much into this, but what are the issues that arise if we don't comply with EMTALA? Well, you know, the state comes in. The state gets reported to CMS, and they send in the state, and the state does an investigation, and then the state sends their findings on to the feds, and the feds look at it, and then they decide whether they're going to levy fines against the hospital, physician, or both. They can technically place us on immediate jeopardy of losing our Medicare or Medicaid funding, which would be devastating, and private lawsuits can come out of it. So there are a lot of downsides to not complying with EMTALA. Are there any other scenarios that you guys have that we've not talked about? Yes.
Thank you. I'm just curious as to what some of the, I don't know, maybe questionnaire, when patients are being transferred, like we get a lot of patients that come from like Murphy, that they're just here for a stress test. Vitals are fine, they're fine. What warranted, you know, how can we determine really what warranted them coming here when that's something that could have been done outpatient? You know, and as far as the EMTALA, like, I just don't see some of the rules on why we get these transfers when some of the stuff could be done outpatient. I don't know if that makes sense or not.
It does, and that's ultimately going to come down to a physician decision. So very often that question comes up on the back end. We've received a patient, and now we wonder why in the world did we receive that patient? What I will tell, let's say, you know, usually the person that raises that question is a physician here. It's usually a physician going, why did we get this patient? But under EMTALA, that emergency room physician over here that sent the patient, they're the ultimate decider. Okay? So if that emergency room physician from that sending facility says this patient needs a higher level of care, and there's a disagreement, they talk to provider here at Erlanger, and they talk, but let's say they disagree, and provider here at Erlanger goes, I don't think so. I think you can treat it there. And this one says, no, we can't treat it here. Guess who wins that? The sending, because they are laying eyes on the patient. So they're at a distinct advantage, and by law, that advantage gives them the ultimate deciding authority. So even if on the back end we say that you probably didn't need to transfer, we would accept that transfer. Because what we don't want to do is get in trouble for reverse dumping, what we just talked about. Right? We err on the side of caution. And particularly when that sending physician says, no, it's emergency medical condition and they need this higher level of care.
And Jane brought up a good point. Murphy doesn't have cardiology, so if the patient's still having chest pain, they're still technically not stable.
Right. And remember, and this is what's so weird, but that medical screening exam does not end, right? If that patient is not stable medically, you're still in the MSC process, and it won't end until that patient is stable, admitted, or transferred appropriately. You don't get out of that piece of it yet. Any other questions? Thank you for letting me take your time at early hour of the morning. I appreciate it. And if you think of anything later, please feel free. There's my extension, 7702. My name is Heather Savedas. I'm Director of Risk Management. Reach out to me, call me, email me. You're welcome to, and we'll talk through whatever scenario you're dealing with. Thank you.
Too early to clap. Well, if you guys will hold on.
Thank you, Heather. I think that was very informative, wasn't it? That helps you get through, doesn't it, making those decisions. Many times I think we think, oh my goodness, here they, I'm going to use an example. Who can I use? Anybody, not Murphy, but maybe Murray Medical, out in the rural county out there. They're not a critical access, but they're just almost close to being one because they're at least 20 miles or about 20 miles from the next nearest hospital. So being an affiliate, Gordon County manages that hospital, so they send us anything that they feel like they can't handle. So you might get something that you think, oh my goodness, why are they sending that patient here? And it couldn't, all of them have Apollo physicians. So we have Apollo emergency physicians, and they're usually talking. And they're talking through the point of, well, if this is positive, we need further treatment. So neither hospital has cardiology, so that might be something you'd even get from a Gordon County hospital. So I think those are good questions. Just wanted to, I know Whitney's going to touch on a lot of this and some policy changes. Just want you to know that there's a committee that meets every Tuesday morning going over different things that we need to do to make our ED safer. We've talked about having the canine patrol to having metal detectors, all those different things. But we do have some things, positive things that are coming and in the works, and I'm going to let Whitney talk to you about all of that. I just want to tell you how much I appreciate you all. The last couple of weeks, you've really been working hard. I mean, you work hard all the time, but specifically the last couple of weeks, we're trying to make our ED, the perception of our ED, be safer, and that means that we have to do a lot of things differently, maybe not convenient for us, but still centered on the patient and what we should do. Perception is a lot of things. From patient's perspective, the number one thing that we get, and from the community, is the hallways. Now, I know that there's times we have to use those hallway beds, but if we don't have to, we should fill up every bed first before we go to the hallway. That should be the last resort. Even if it's more convenient for us for them to be in the hallway, it's not what the patient views that should happen, so that's going to be your decisions. But I just ask you, if you will, to try to avoid putting patients in the hallways. Sometimes we have to, but let's fill the beds first, because that is a perception that is in the community that we're examining and doing treatments and things out in the hallways that we shouldn't be doing. So that touches a little bit on how we care for and do we not have enough space, such as things Heather talked about. And we have the space. Sometimes it just means we have to change. And ED nurses and paramedics, you all know, techs, you all know that that could change just about every 30 minutes. And that's just the nature of the beast, I guess, working in the emergency department, is those constant changes. But I do want to tell you how much I appreciate everything you're doing. It's a challenge. Yesterday was a challenge with all the mental health, behavioral health patients that we have, and finding sitters and doing things differently, but you all seem to rise to the occasion, and I appreciate it very much. I'm going to not take any more time, and I'm going to let Whitney come on up because she has some very important things that she wants to talk to you about. Thank you again. Oh, question.
Oh, okay, I guess.
You're on now.
I mean, I'm a loud talker anyway, but I'll use this microphone.
Sure.
So, like, I know sometimes in the ER you'll hear our physicians say that, like, they're on auto accept, and that term gets thrown around. So, I mean, I guess when we do accept these transfers, is it true that sometimes it's just auto-accepted under the physician's name and they're not really communicating and getting a say in the scenario?
There are certain situations that we auto-accept, such as traumas. We auto-accept those traumas. You do get a brief report and you hear that coming over the radio, but we auto-accept those trauma patients because there's no other place for those patients to go. STEMIs, strokes, Whitney, what else?
STEMIs,
Stroke, surgery,
surgery. I was trying to think. There's some, but
trauma.
they're accepted by protocol just because we're the place they would come. There's no other place for them to go. Now, surgery, and I know this is can be a little confusing, but surgery, even though the NEDOCs are high and we're on advisory, they still accept surgery patients. Then, though, I do think, we had an example last week, it is a physician to physician typically, sometimes maybe not, but we had a hand, a severed, not hand, but a severed digit. And so that was, should have been an automatic. Patient didn't end up coming here because of the specific mechanism of the cutoff of the finger, but typically they will talk just to see what's going on. The surgeon likes to hear, but there are some cases where they come on automatically too, even though we're on advisory, but that's just surgery patients. Because they say, well, you can go on advisory in the ED, but we still have capacity, so we'll take the patients. Hope that answers.
Yeah.
Anything else for me? One other thing, and I don't know when EVS will arrange with Whitney, but was talking to Dave Peterson over the weekend, and he does plan to do a terminal cleaning for sections. We'll have to do it, obviously, in sections when the ED is not busy, so just get prepared for that. It's a little inconvenient, I know, but he wants to get the floors really, really clean, the walls, everything, and so that's coming up. And I haven't talked to Whitney about it, so we'll see when that's going to happen. Okay, thank you.
So if everyone that normally